And good afternoon, everyone. Thank you for coming for what promises to be a very informative session. We're very pleased to have three very accomplished women join us today from the Sinai Health System, which is a collaboration with the University Health Network and the Toronto Central LHIN. Dr. Asenath Steinman received her medical degree from the Sackler School of Medicine in Tel Aviv and completed her residency in internal medicine and fellowship training in geriatrics at Mount Sinai Beth Israel in New York City. She's been a geriatrician at Sinai Health System for 8 years with a focus on geriatric rehabilitation. Agnes Kulinek is an RN, received her Master's of Nursing from the University of Toronto and her gerontological nursing certificate from the Canadian Nurses Association. Her focus is on community-based geriatrics care, and her goal is to help elders to age in place. We certainly agree with that goal. Shayna Pilz completed her Master's of Social Work at the University of Toronto, specializing in gerontology. She has a wide range of experience helping people to recover from accidents, mental health issues, strokes, and has experience assisting those with dementia and a range of cognitive disabilities. She connects elders and their families with community resources. Our presenters have agreed to take questions at the end of the presentation, so I'll be calling on you then. You can also post your questions on chat. And I also want to remind everyone of how to raise your hands so that I know you'd like to ask a question. So if you go to reactions at the bottom of your screen, you click on it, you'll see raise hand. Okay, so if you raise your hand, I'll know you have a question. Otherwise, there's a chat. You can see chat with a little text box. You can click on that and you can send a question to everybody in the group or make any comments to anybody in the group. And I'll keep my eye on that so that the presenters don't have to. And we are recording the session. So without further ado, I will turn it over to, I think, Asenath, you're going to begin, right?
Yes, thanks so much for having us. Let me share our slides. Okay. All right. And there we go. All right, so thank you so much for having us. We really appreciate it, and we're actually quite excited to speak to a group that's, throughout Ontario. We don't usually get that opportunity. So we'll talk a little bit about our program, and it's called the Independence at Home, or oftentimes we'll refer to it as IH, Community Outreach Team. And I will introduce you. We got a wonderful introduction. So I'm Asenath, I'm the geriatrician, and I'll let Agnes and Shayna just say a quick hello because we're going to be presenting together. So bear with us.
Hey everybody, yes, I'm Agnes, I'm the registered nurse on the team.
And my name is Shayna, I am the social worker on the team.
Okay, so again, we're sort of presenting together, so bear with us as we sort of go through the slides and hopefully not talk over each other because we're very excited and have a lot to say. So these are some of the things we're going to talk about today. It looks like a lot, but don't worry. We want to leave a lot of room for questions at the end. That's what's most exciting for us to do. So we're going to talk a little bit about older adults in Canada. I think that you're a group that knows quite a bit about this. We'll talk about the overview of our team, of the IH team. We'll specifically talk about our team roles, our patient or client characteristics, what our clinical assessment actually involves, and then we'll give us some cases that, based on real life cases. And then, like I said, questions, comments, we'll leave a nice amount of time for that. So older adults in Canada. So surprise, surprise, there's a lot of older adults. Based on the most recent 2021 census, the older adults defined as 65 plus made up just a little bit over 7 million people, about 19% of our population. And of course, we know that in the next almost 20 years, a little bit less by now, we're going to have a really, really big expansion of our older adult population, growth by 68%. We have it divided there by province. And of course, also related to that, the life expectancy is going to increase. So that's hopefully a nice thing. Women are going to rise the life expectancy to 86.2 years, men to 82.9 years. So again, this is not hopefully news to us. We all know that the older adult population is going to be increasing, and that's why it's so important for us to invest in our older adult care. Related to that sort of picture of where people are going and where are we really aging, this is just some stats from 2 different surveys, one by the Canadian Institute of Health Information, one from the National Institute of Aging, and just really getting an idea of where people want to age. So 96% of older Canadians said that they would do everything possible to avoid going to a long-term care home. About 1 in 10 newly admitted patients to long-term care could have potentially been cared for at home. And the long-term care residents who could have potentially be cared at home, the ones who actually were admitted, are a higher percentage of them were ones that lived in rural areas or ones that lived alone. So I'm just bringing these sort of topics up, not going to really go into details of like how could they have been cared at home specifically, except to sort of put it in the context of, well, maybe with teams like ours, like a geriatric outreach team, our goal is really to help with the aging at home. So just sort of putting things into perspective for us. So let's talk about our team, the Independence at Home Community Outreach Team. So before we get into our specific team, let's talk a little bit about the evidence behind, in general, geriatric outreach teams. So some of the positive things that geriatric outreach teams do is they show to reduce the mortality rates of younger geriatric patients, and we define that as 65 to 80-year-olds. So that's a wonderful positive thing. The other thing that has been shown through evidence is that geriatric outreach teams improve the functional status outcomes, the various ones, and reduce nursing home or long-term care admission in all geriatric patients. And there are certain features that make a team successful, and some of those features include a multidisciplinary team, which ours is. Most teams are, but the composition of the teams are very variable. The other part that's sort of a successful feature is when we are doing our assessments and our evaluations and examinations, we use a CGA, which is a comprehensive geriatric assessment, which we'll talk about in a few slides or so. Another really helpful feature to make a successful team is having follow-up visits. So it's not just a one-time visit, make recommendations and hope they get followed through, making sure that there are some follow-up visits to actually achieve those goals are important. And the other thing that would be helpful is ideally have these teams close to other geriatric services. And that, of course, will really be variable of where the teams are and where other geriatric services are located, which is a little bit of an issue depending on where you live. Okay, I'll bring it over to Agnes.
Yeah, so this slide talks about the healthcare system as a whole. And it's pretty neat because it does show us how it's slowly trickling in to a lot of different areas of the healthcare system. So whether it's outpatient, inpatient, community, or emergency department models, we are as a healthcare system becoming a lot more cognizant that there are a lot of older adults that need very specialized and well-informed care. So and we just pointed out that we are there with the community model as a community outreach team.
Yeah, and again, just highlighting the point that this is a specific slide about the continuum of care at Sinai in Toronto. So these are all different programs that are available in different measures. And again, just highlighting the point that it really depends on where you are and sort of what programming is available. So I wish we can say that this is the case everywhere, but it's not necessarily.
So hi, everybody, my turn. So I'm going to go into a little more detail of the Independence at Home team and really the members of our team. As we mentioned earlier, we're an interdisciplinary team, so we have different specializations and we work together to provide care for our patients. So we have a pharmacist, we have 3 different geriatricians. We have a geriatric psychiatrist who works more on behaviors and those kind of symptoms. We have 2 social workers and 2 registered nurses. And we also have a home and community care social services care coordinator. So she is our liaison with home and community care regarding other services. So the other professionals, such as occupational therapists and a dietitian, may be accessed as required through partnering with home and community care support services. And we also work in partnership with the patient's primary care physician. So their GP, and we connect with them regarding the services and the referrals and any kind of feedback that we might have to make sure that there is a continuum of care and that they are aware of any recommendations or changes that we make. And I can also say that our services are covered through OHIP. So us coming into a patient's home is free of charge. Next slide, please. So just to kind of show the ways that we interact with our patients. So on the left, we link older adults with the right in-home outpatient or inpatient care and rehabilitation options. So if sometimes patients need a little bit more physiotherapy or occupational therapy or any other alternatives like that, we can connect these patients in the community with other services medically based within their homes or even in an inpatient environment. So we optimize the home and community care support services and other home care support services and activities to promote the individual's independence. So this comes in different options like making sure if their nutrition is an issue, they could see a nutritionist through home and community care, or actually accessing food, we can make sure that community organizations are able to send Meals on Wheels or other hot meals, sandwiches, and so on. So that's just a brief example. We provide and refer individuals to a range of specialized geriatric services. So if we notice that a more enhanced team might be necessary for maybe mental health or diabetes education or kidney care or chronic pain, we can make those referrals to other specialized geriatric services or clinics, or the geriatricians ourselves within our team for ongoing follow-up and support. We also work on a broader recognition for beyond the patient. Often their families and their caregivers require a little bit of attention as well to kind of prevent things like caregiver burnout or offer respite care. So we assist individuals and caregivers with care navigation and accessing caregiver support. So whether that be kind of additional counseling, additional support groups, or that respite care that I mentioned. Next slide, please. So our structure, how do we kind of have our patients, connect them with care, and what is the actual process for us doing our jobs? So I can start with triaging. So we get our referrals, and I'm sure there's going to be another slide that explains how we get our referrals, but they are triaged either to a social worker, a nurse, or a pharmacist. So we take a look at the referral, we understand what are the issues of concerns or the goals as recognized by the referring physician, and we assign that referral to one of the specializations we mentioned. So once they're assigned to the nurse, the social worker, or the pharmacist as most appropriate, that healthcare practitioner will contact the actual patient and or their caregiver. So sometimes we'll speak to the senior directly, sometimes we'll speak to a representative, a daughter, any other family member, or maybe even someone else managing their care, like a caseworker, case manager, and so on. We try to book the first appointment with them in their home. It normally is in their home, a safe place where they're comfortable. If they're homebound, we understand they can't leave. And so we'd conduct that first assessment. So we ask as many clinical or personal social questions as possible to best understand their care, how they're managing right now, and where some gaps in their care are. Then we bring this information to our weekly review with the entire team. So we explain who we saw, what their concerns were, and that's where we share our ideas. What works, what doesn't work, what options are available to meet these patients' goals. And we also ask about any particular additional assessments that might be necessary. if I notice there might be one of my patients has a confusion regarding medications, I might ask the pharmacist to do a follow-up appointment. Or if we're noting there's issues regarding medical needs, behaviors, or gosh, even in incontinence or other issues like that, maybe we'll have the nurse or the geriatrician go in. And then after, if the goals are met before the 3-month time period, or 3 months at maximum, really, we tend to discharge our patients. We're really a short-term intervention. We recognize that we want people to live independently and as strong as possible with the supports we put in place. So we take those 3 months to put as many supports and referrals and connections in place as possible. Then we communicate with the GP and the referring physician, say this is what we've done, this is our effective input, and we discharge or refer to other clinics if necessary for additional support and follow-up. Next slide, please. So this is actually one of the resources that we both use as well as connect with other people. This is a beautiful map of Toronto that actually connects seniors with various different geriatric resources. So it could be outpatient geriatric teams, inpatient geriatric teams, mental health teams, and various other actually inpatient and outpatient hospitalized programs that are able to connect patients in the community to other services that are closest to them. I know I use this website on a regular basis to help my clients. So this website can connect people to our team as well as others in the area.
Yeah, and just to add that the RGP, the Regional Geriatric Program, this is of Toronto, where we're at, but there are regional geriatric programs around Ontario. So there are resources, again, varying of what's available, but around there's, Eastern Ontario, there's one, I forgot what the Ottawa ones, and etc. So there's lots of different ones around Ontario you might be familiar with as well.
Mm-hmm.
Okay, so I'm going to talk a little bit, not too much details about how we're funded. We are OHIP covered, so you can imagine where the funding may be coming from. Again, we are a team. We started in 2016 with a pilot project grant from the Ministry of Health, etc. With the support of these organizations, we were able to add some of funding from their buckets of funding, as well as sort of continuing on past the first year. We were able to show that we were quite helpful and meaningful. And so these are different, mostly, we have UHN and Sinai as our big sort of hospital supports, as well as more community supports in terms of Reconnect, and then through the Midwest Toronto Ontario health team. So just one thing to note about that, and something that I've sort of been learning as I continue, being a physician here and sort of getting the sort of back view of the finances of how things get funded. I just wanted to mention that we got. It's important to note that we have funding from hospital-based medicine, hospital-based, hospital-based, because they are the ones who get the majority of the funding sort of buckets from the government. So, as opposed to sort of more community-based organizations are probably getting a smaller piece of that pie. So just keeping in mind of, how we want to potentially have someone would want to fund a different, outreach team. You have to think about where you're getting your funding and who sort of could help out with that, just to keep that in mind. But we're very grateful and very happy that we are continuing and having our support from these different organizations. Okay, we'll talk about our team roles.
Mm-hmm. Yeah, so like Sheena mentioned, there's quite a few different individuals on the team. Something that I also thought to mention in keeping with your slide just before this, that actually the different providers on the team are sort of from different areas within the, they're from different organizations, and that sort of brings a really unique flavor to the team, as well as being from a different professional background. So what we're going to do now is we're going to review how the geriatrician, registered nurse, and social worker function as part of the geriatric outreach team.
Okay, so I'll start. I'm the geriatrician. So I'll just make sure we all know what a geriatrician actually is. So a geriatrician is a physician or a physician who studied internal medicine or adult medicine and then specialized in specifically geriatric medicine. So we focus on the aging process. We have skills that help with the diagnostic, therapeutic, preventative, rehab aspects of illness and health, I guess we can say, in the elderly. Really important aspect, obviously I'm coming from a medical background, but a really important thing that I always like to mention is that we really, as a geriatrician, are working with an entire team. Like geriatricians cannot work in a vacuum, just on the nature of the approach that we take and sort of the complexity of our patients. So while we are sort of the medical specialist, we definitely cannot work in a vacuum. And then I wanted to bring the concept of that comprehensive geriatric assessment, because this is really the tool that we use to assess and make plans for our patients. And there's a lot of evidence showing that the use of, this comprehensive geriatric assessment, looking at all these different domains, has really positive impact. In an inpatient sort of setting, it reduces length of stay, reduces mortality. In an outpatient setting, again, we see some decreased mortality, decreased institutionalization, et cetera. So there is evidence to support this method. And again, the idea here is just to show the complexity of the entire person. So it's not just the physical health, not just the medications, not just the comorbidities, the high blood pressure, the heart disease, etc. It's really looking at the physical health in addition to things like the cognitive, emotional health, the social supports that people have, their financial sort of status, because we all know that unfortunately has a big impact on how kind of care that we can get. And also the external environment. The fact that it's so complex and so everything is so connected makes it very attractive to why I actually enjoyed and went into geriatrics. And I think there's also a really nice silver lining to this where because everything's so interconnected, if you make a small improvement in one area, it can actually have a big improvement in other areas. So when you make a small change to the external environment, it actually can have a huge impact on all these other domains. And I think that's sort of the framework that we go into in geriatrics in general and specifically in geriatric medicine. So I just want to introduce that because these themes will come up again and again.
Thanks, Dr. Simon. So as the registered nurse, so there's two of us. There's an additional one that was hired 2 months ago. So it's really exciting. But the registered nurses on the team were passionate and knowledgeable about age-related changes and how to accommodate them. We are focused on learning about each older adult's goals in improving or maintaining their current health. Just a side note about that, and what that means is that, just being able to, as a healthcare provider, go in and learn about what's working well and maybe what's not working well for any particular older adult and or their caregiver. But really listening in on what's important to that individual. So I might say like, oh, let's work on your incontinence, but somebody might say, hey, like, okay, but this is really what is a priority for me. This is what I think could have a really big impact. And this is what I'm motivated on working on as I'm aging. Can we do this together? And so in that line, we're offering strategies and supports in addressing those very common multidimensional geriatric issues, such as constipation, falls, incontinence, and delirium. And like Dr. Simon mentioned, a lot of different things are within somebody's health. They're very related. And there's often many things that are influencing any one area of somebody's health. So it's really trying to unpack that with someone. Next slide.
Hi, everybody, me again. So as one of the two social workers as part of the team, we have a responsibility to be well-versed in community resources to best accommodate and support patients aging in their home. There is a wide variety of community resources available, specifically in different geographical areas, as well as different cultures, language, and specializations. So I try to use a patient and family-centered approach with emphasis on strength-based perspectives. So what exactly does that mean? I start with the exact patient, what it is their goals and wishes are, what their focus is for their healthcare. We establish some goals in regards to that, whether it be to remain in the home, to have more supports, to be more active, to be more socially active, to be more physically active, or just essentially to maintain their independence. And then I broaden it into the family. So whoever their caregivers are, whoever's really providing support to that senior so that they are in the most healthy, optimal state to provide care for their senior. So they're not at risk for burnout, or if they are burnout, then we have the ability to rejuvenate them. I also have that emphasis on strength-based perspective. So that means I work within the existing skills and capabilities of the senior. If they do have the ability to be a little bit more mobile, then we work with their strength. If they can only stand for a short amount of time, then we see what they can do while they're standing. If they're working on their pain management, then we focus on what they can do when they're not in pain or when they have minimal pain. Same thing with sleep and so on, and other physical and social elements. So I target supports, as I mentioned, both to the patient and the caregiver as necessary to work with the entire family, really. So many of my topics of concern range from environmental safety. So hopefully the patient themselves has all the equipment to bathe safely, to get in and out of their home safely, to ambulate safely within their home, as any other equipment to have that exercise or to do their activities of daily living, such as eating and being mobile, as mentioned. As well as their financial security, to make sure that their long-term, well, not necessarily their investments, but that their accounts are secured and safe, and either the money is being used for themselves, so kind of prevent any kind of elder abuse or kind of financial abuse, neglect, and that kind of thing. Or God forbid, they do get even more sick or they pass away, there's some direction both for their future finances as well as their goals of care for advanced care planning. I also talk about housing. If somebody is in a dangerous situation, at risk for eviction, if they're experiencing hoarding issues, or if there are issues of bed bugs or roaches or anything like that, then I can help connect with other community organizations, emergency cleaning or extreme cleaning like that, to kind of help them navigate that side of the system. Or if they're experiencing lots of issues with mental health or kind of coping in that regard, then I can connect them with some counseling or CAMH or any other specialized service to kind of address those issues longstanding. And then as well as the activities of daily living. So it might be additional social supports to get them out of their house. It might be issues of transportation to make sure that they have methods of actually getting out of their home and interacting with their communities to make sure they have their groceries or their medications or any kind of additional excursions and that kind of thing. And as I mentioned before, and regarding that caregiver support, if they needed respite, caregiver counseling, one-on-one care for just kind of being able to bounce ideas off of another person to recognize the challenges that comes with being a caregiver. So I do my best to have a large awareness on people's different backgrounds. I recognize that everybody has a different religious background, spiritual background, cultural background, language barriers. So within the community resources and different kind of goals that I've already established, being able to have that variety to help Well, Toronto's a very diverse city, so helping all of those different cultures and languages, whether they be Greek, Italian, Portuguese, Sri Lankan, Mandarin, and so on, the list goes on. So connecting people with the correct meals and food and dietary concerns and languages and social interactions with their day programs and, well, community-based social interactions. Now, all while really respecting their autonomy, allowing that decision to, the last part of that decision to be on behalf of the patient themselves, so they can determine what they're most comfortable with. And because they're the expert in their own lives. Next slide, please.
So you can see it's no joke that we really need this sort of group effort. And of course, this is just not even talking about the other members of our team that also have, unique roles as well. All right, so we're going to talk about some patient client characteristics. So over to Agnes.
Thank you. So it's important to note that we do try to serve a specific subset of geriatric patients. So to help the referring physicians or the referring nurse practitioners, as well as, advocating family and friends for them to know exactly who we do see. We have created inclusion as well as exclusion criteria. So to the individuals that we do want to see are those who are 65 and older, although we do dip down to individuals who are 60 if there are cognitive concerns. So that's where we are flexible. The individuals that we see are medically and socially complex. They're community dwelling. So their home can be a shelter system, it can be assisted living, it can be a retirement home, it can be the apartment, their house, wherever it is that they call their home within the community. So this individual living in the community who has had recent functional decline with the potential to regain function, or there's somebody who is struggling for other reasons to remain in the community. They really want to age in place. They're having some, a tough time for various reasons. And that's where the geriatric outreach team will help. And that's really who we want to see. It's somebody who is more ideal for homebound older adults who cannot be well served by our ambulatory care services. And of course, we do have a catchment area. We'll show you a map just after this slide as well. The things that we would like to pass on to other more appropriate teams include crisis intervention. So there are teams that can respond sooner, who can take on more of a role in an individual's case. And that would be things like crisis support and outreach services. So that's what we have here in the GTA, the Greater Toronto Area. It's the COSS team. If it's an individual who needs urgent medical support, again, because of the time lag and because of how intensively we can be involved, we do recommend other referrals. And if it's somebody who lives in long-term care, then we also don't get involved in that case. Next slide, please. Okay, so here we are. This is I'm seeing the questions pop up. Okay, and I'm excited. So this is our current catchment area is in the blue. So it's south of St. Clair Avenue. We have the Don River on the east and Parkside Drive and Keele Street on the west. Yeah, and the other, as the RGP Toronto map showed us, there are other outreach teams in various areas. So we've communicated with them that this is sort of the area that we do want to stay in, so that we have a really good spread of services. But having said that, having gained 2 more individuals, 2 more team members, we will be looking at potentially expanding our geographical area as well. I don't know if Dr. Steinman, you want to speak more to that.
Yeah, I mean, the idea is in general, we don't want to, you know, duplicate services. So this is sort of strategically done, where, you know, north of us there's another outreach team, to the east of us there's another so it's sort of strategic,
Mhm.
but yeah, but we're hoping, you know, there are some, you know, areas that don't have as much resources available. That's mostly to the west of our current catchment area. So that's the whole
Mhm.
idea of expanding our outreach teams, and to reflect sort of where the need is. So it's we're getting there now that we have more staff. We hope we can expand a little bit more.
Perfect. And as I mentioned, with the inclusion and the exclusion criteria, the individuals who are referring to the team are physicians as well as nurse practitioners. But what is exciting is that these providers are are really sending referrals from a great variety of places. And that's really exciting because it means that that we're known in so many different spots of our healthcare system. And interestingly, this has sort of changed over the course of us being a team for the last, I guess, seven or so years. Um, so a lot of referrals right now are coming from primary care, which is amazing because we do really want to help those family doctors. They're there in their offices, kind of working, perhaps not on a team. And how great is it that you can send a referral to a geriatric outreach team and you have access to a team who has access to the patient at home. The other top referral spot is from specialists. So um, some individuals will go in to see the osteoporosis clinic or they'll go to see their kidney specialist and they will say, I think that you'd benefit from this program. That's how we get the referral. Also, the acute care, inpatient rehab, and emergency. Um, I think their focus is often on how can we make sure that when this person goes home, they're with us here in the institution, away from their home, and when they go home, I want to make sure that I get a little bit more eyes on them. There's something about their just their whole situation that makes me feel a little bit icky, and I do want a little bit more follow up on these geriatric concerns. So that's where we look at the referrals from those folks.
Okay.
Next slide.
Okay, we'll bring it over to Shayna.
So this is one of the scales that we use to best kind of understand and quantify each patient's kind of different level of what they are currently able to maintain by themselves or how much assistance they would need within the community. So it goes from someone who is very fit, they're robust, they're active, they're energetic, and they're very motivated. They exercise regularly, and they're among the fittest for their age. And then it slowly kind of increases in terms of both physical health and mental health, and cognitive health. Weaknesses as it kind of deteriorates. So we go into someone who might be well. So people have no active disease symptoms. They don't exactly fit within the first category. They don't exercise as often. So maybe they're active occasionally or seasonally. I'm sure many of us might have those kind of statements of I go out when it's warmed, but not so much when it's a little chilly out there. Or people are managing well. So they have some medical problems, but they are well controlled. So they're regularly making their appointments, they're following up with their specialists or their family physicians. However, they're not regularly active beyond just maybe a walking routine, maybe, regular excursions kind of thing. And when we go into concepts of being vulnerable, they're not necessarily dependent on others for daily symptoms, but they have limited activities, really. A common complaint is feeling slowed up, or you're tired during the day. So maybe you have some fatigue. You're not able to, you can start an activity like maybe cooking or cleaning, but it's challenging to kind of complete that activity, and you need a rest, or you might need to put it off for the next day. Then we go into more common, so mildly frail. So this are people who have more evident slowing. They may need more help or for a higher, the independent activities of daily living. So finances, transportation, heavy housework, medications. Typically, they're mildly frail, progressively impaired shopping, walking outside alone, meal preparation, housework. So these are kind of the larger activities that need to be done on a daily basis, but might need to be done by somebody else. Then we enter moderately frail. People need help with all outside activities and with keeping house. Inside, they often have problems with stairs and need help with bathing. So now we've entered the difference between larger activities like the light housekeeping, as well as the grocery shopping and transportation. Now we're getting into kind of the more personal things, so the bathing and the eating and those details. And they might need minimal assistance, so queuing, standing, dressing. Then we go into severely frail. So somebody who is completely dependent for personal care for whatever reason, whether it be physical or cognitive. Even so, they seem stable and not at high risk for dying. So that might be within 6 months. Then we work into very severely frail. So someone who's completely dependent, approaching end of life. Typically, they could not recover even from a minor illness. And it's very specific. We show this image of someone who's probably bedbound, or they have a lot of difficulty getting out of bed or need a lot of physical assistance to ambulate possibly to the bathroom or so on. And then we have someone who's terminally ill. So they're approaching end of life. This category applies to people with life expectancy of less than 6 months, not otherwise evidently. And we do tend to keep in mind of somebody's cognitive status when we are scoring someone's abilities on the frailty scale. So we're keeping very in mind of what is actively happening on a daily basis. Not necessarily what someone has the potential to do, but what is happening. How much are other caregivers and other supports in place to make sure that somebody has the ability or that their needs are being met. And then we'll move on to the next slide to kind of show who our traditional patients are. That is still me. Okay, so from these numbers, oh, here we go. So the vast majority of our patients are either that mildly frail stage or that moderately frail stage. So we're talking, and I'm jumping around on different slides. So we're talking that 5-6 range. So that's people or persons who are needing a little bit more assistance for their, like in the community activities. So the shopping and the heavy duty cleaning and helping with their finances, transportation and so on. As well as beginning with that moderately frail. So people who need a little more assistance with their bathing and their nutrition and so on. We do have some persons, so about 9% of people who are managing well. So that was number 3 on that chart. We have about 10% who are vulnerable. So that was number 4 on our chart earlier. So not necessarily dependent, but are at risk. We have, I think, 1% of terminally ill, so very, very rare within our team. 9% for severely frail. So that was our number 7. So they're completely dependent for personal care. And that was all of our categories. So as you can see, the referrals that we received, we have the ability to make a large impact on our client and our family's lives because they still have so much capability to still be active. So if they're only mildly frail, there's still lots that they can do. And if they're moderately frail, there's still lots of supports that can be put in place to maintain their independency and safety within the home.
Just
Next.
one thing I'm going to mention, and just because it's sometimes I think hard to see because the two blues are so similar, but that bigger slice, the 9%, is actually severely frail, and that smaller one is managing well. So it makes sense that people are managing well aren't being necessarily referred to our program, and then we have that smaller but relatively important 9% that are the severely frail. So just to clarify that, so the colors are a little similar, and I have a nice big on my screen, so I can see that clearly. So I apologize. Okay, next slide.
Yes, please.
Okay, Agnes. Oh, yeah, Agnes. No, still Shayna, sorry.
Still me. So we do try to keep track of many of the larger referrals that we make. We call them linkages. So we keep track of the larger resources that we connect people with. So the majority, I'd say anywhere probably closer to 130 or maybe 135, we're making referrals to community support services. So that would be making sure somebody has in-home physiotherapy or an occupational therapy home safety assessment, or if they're getting PSWs to come in for other home and community care services. Sorry, let me rephrase. The community support services, that larger number that I mentioned, that would be supports like Meals on Wheels, day programs, respite care, and other community services. So these services, these organizations, they might sound familiar, could be, St. Stephen's West Neighborhood House, Reconnect, or even back up in North York, like Lumacare and so on, and Circle of Care, like myself. Then we have the home care services. So that's community care, where we might make a referral for a dietitian, occupational therapy for home safety, just to see if somebody needs a walker or a wheelchair, or what's the best kind of mobility equipment they need for their bathroom, for proper transfers and so on, or the physiotherapy like I mentioned. Then we go into the geriatric day hospital, which is actually a fantastic program that's connected to our geriatric day hub. So where patients could come in and have physiotherapy on a regular basis, or connect with our OT, or even have a follow-up appointment with a geriatrician. We also have our caregiver support program. So that might be Caregiver Ontario for counseling one-on-one or in a group. And then other programs like falls prevention programs to kind of do a little bit more exercise for people who live in the community. Homebound primary care, which I want to say is probably on the up and up, because we recognize that many of our patients are either homebound or cognitively impaired or have difficulties leaving the home. So it is much more flexible to get a homebound primary care physician or team that can regularly go and see that patient in their home and provide medical care on a regular basis. We also make primary care referrals. We do Wheel-Trans referrals. As I mentioned earlier, lots of times patients suddenly need Wheel-Trans. They're not as mobile as they used to be, or they might not have the finances to regularly have Uber or taxis or family who can take them to their appointments. We sometimes connect people with other outreach teams. The Mount Sinai Hospital Reitman one-on-one support, so that's for caregiver as well. Then we do outpatient geriatric psychiatry clinics, the med clinics, community falls and exercise programs, inpatient rehab, and the careers group, which is another caregiver support stuff. So these are just an example of many of the regular linkages that we make. We also do some pharmaceutical, or maybe we do some exit seeking monitoring or medication dispensers, or even enhanced PSW hours. So there's lots and lots of different community supports that we connect people with.
Yeah, and I'm just going to add here that obviously this is very Toronto focused. Of course, that's where our catchment area is, and it'll be very variable, obviously, depending on where people live, what the resources are in that community. Usually around larger cities, you have more supports, and that's just somehow population, I'm assuming, related, etc. One thing I'm just going to mention, because it's a hot topic of finding primary care, and that's a big issue of finding primary care doctors. We put in a lot of referrals to connect patients with homebound primary care teams, or just primary care teams to begin with, or a physician. A lot of wait lists, just so you know, just so you don't think, oh, Toronto, everyone gets a homebound primary care team. There's a really long wait list, and when people do get accepted to those programs, we're very happy and appreciative. And the other thing that I wanted to see is if, Agnes, do you have any other sort of, because this is really, like, again, from my perspective as a doctor, this is what I need the team for, and this is sort of the crux of what we do to connect people, and this is sort of the I think with experience of us sort of learning what's available in the community, because it really changes all the time. Someone gets funding, someone doesn't get funding. This program is now available. This program is now defunct. So this is really the sort of the crux of what we do and our networking to sort of be aware of these programming. So Agnes, do you have anything else you want to add? Because this is just really an examples of what we do.
Yeah, I'll just add that oftentimes when I'm making that first phone call to patients or their family, they'll ask about, like, okay, so what do you do? And so I will provide these linkages as examples. So it's just really about, it's our responsibility to keep on top of what's available in the community. And like you mentioned, things are changing all the time. So keeping these services front and center, um, and really listening to the individual to kind of decipher what it is that they actually think would be realistic and feasible for them. Um, so it's these pulling from the community, pulling things that are available to help meet their needs, in addition to really any of the education and the health counseling that we can do as professionals. So I think it really sums up, like, how our team functions.
Okay. So we'll go on now so we talked about sort of what our team consists of. We talked about, what in the end our linkages are, etc. But now let's go back to, what is it, our actual assessment? Like, what are we looking for? What are our tools that we use? What are sort of things that we're looking at? So I just bring you back into where we are. We're in our assessment area. And again, just to remind us that this is sort of the lens that many of us are using when we're assessing our patients, and using that comprehensive geriatric assessment and that lens with our patients. So I'll bring it over to, I guess, Agnes, Sheena, whoever sort of wants to go for it.
So yeah, that's great that you actually mentioned that comprehensive geriatric assessment lens as part of the assessment, because we already start to ask for that specific, very broad information within our referral form. So right now you're seeing the next couple of slides will be, we've just pulled it directly from the referral form. And it does let you see the different, I mean, we've been talking and mentioning these different areas of people's health and well-being throughout this presentation already. Here they are again, and it does, we are asking our referring docs to also keep that in mind. This helps us to really hone in on which would be the best individual to get the ball rolling with that patient or caregiver. And so just getting them the most appropriate support, even though we're a team, so they'll get sort of the team approach too, but just who's the most appropriate clinician to go in initially. So so let's pretend we are a family doctor, and you might potentially be seeing a patient in front of you, and you're thinking of the geriatric outreach team. So potentially this individual has had a lot of ED visits within the last 12 months. You're concerned. Sometimes it's different things. Sometimes it's, gosh, it's just the same thing over and over. You want to let the geriatric outreach team know. There might be some safety concerns that you've identified. Maybe this person has been having a lot of falls. Either this is a really new problem or this is an ongoing problem and you need a totally fresh set of eyes on the issue. Mobility issues. Yeah, you'll want to let the geriatric outreach team know how they're moving around, what they're using. In terms of medications, maybe you've identified or the family has voiced some issues about, gosh, like, do they really need to be on so many meds? And, or can we use medications to help with this issue? And so that's where you might flag that for the geriatric outreach team. Management and adherence is also often a topic that's brought up. So thinking of how to use the environment, technology, or other supportive people to their full potential, so that the medications are taken as prescribed. That's often a topic. We get concerns flagged about incontinence, about constipation. There might be pain management issues, sleep issues. Some patients talk about either not being able to fall asleep, not being able to stay asleep. So we're really looking at, what have you tried already? How did it go? Okay, and what are you interested in trying out? Because these are some of my recommendations. So that's basically how that goes. If there's been some unintentional weight loss, that's a red flag that we want made known to us. If there's some nutritional issues, so this is very wide ranging. If there's some access to nutrition issues, functional decline. So if somebody was able to do all their own groceries and do all their own banking 6 months ago, and now they're not able to do that anymore, that's really a concern. And we can work with them and their support system to figure out why that's happening and what we can do about it. There's swallowing issues. We want to know about that as well. Speech difficulties. It's a long referral form. If there's driving concerns as well, our physicians are really making sure that if this is a person who would not be safe driving, that needs to be reported. And also letting us know if this is somebody who's homebound and if there's any risks in the home. Yeah, that's helpful for us as clinicians to know as well.
Agnes, do you
And
want me to take the last two?
sure, why not?
In addition, so as we mentioned, this is how a physician might fill in the referral form and help us best triage, so the first person can go in and see the patient. Because sometimes there is a bit of a gap between getting the referral and us going in. So sometimes things change a little bit. So this category that raises awareness for a patient is their cognitive or their behavioral issues. So any kind of large cognitive changes, cognitive decline. So there's an increase in kind of wondering where they are, or they're starting to get concerned or suspicious of others or paranoid. If there's behaviors of losing things, or possibly like the psychological symptoms that we're mentioning, that they're not being managed well. So there's increased agitation or frustration. If there might be issues of mood, so they might have a low mood, feeling depressed, they're not actively involved in their community, their friends, or they're distant. If there's the lack of happiness or enjoyment in life. Suicide ideations, if there's risks of past attempts or recent attempts, as well as other issues of verbal or physical aggression. There have been times where we've gone and seen family members who have very complicated relationships with their families. And it's what kind of navigation we can do within that. We can't change any family members, but how do we kind of encourage a little bit more of a cohesive unit going on? If there's any issues of delusions or hallucinations, often if we were to have maybe a referral that comes from the emergency department, if somebody recently had a urinary tract infection, and there was a lot of confusion and disoriented that came with that. Just kind of following up on those symptoms. Have most of them faded? Is there any kind of medication involvement that needs to be done? If there's issues of wandering or even exit seeking, we really want to focus on a patient's safety. Probably this is one of the largest reasons that a family physician might send us the referral, because they might know of a symptom, but they might not have the ability to go in and see the home and make proper recommendations to promote someone's safety. So they make the referral to us so that we have that expertise and interprofessional team to kind of look at a client's situation and make those referrals and connections. Might be issues of substance abuse, whether it be a long history of alcohol abuse and intake, and what kind of connections could our team make if someone's ready to make a change or even thinking about it. And then issues of self-neglect. Sometimes if someone's living alone, they really do need a little bit more assistance, but they really have no idea who to go to, how to go to. They don't have family members. So that's where another family physician could call us in and say, this person just needs a little more attention because they're alone. Next slide, please. Then we have our psychological categories. So this goes into that larger family structure that I mentioned. Are there issues of caregiver stress or risk of caregiver burnout? And if so, how severe is it? Could this caregiver really just not be able to continue functioning? I've had situations where a caregiver actually was so hands-on and so detailed and loved their mother so much, they weren't expecting it, but suddenly they actually had a heart attack. And thank God they were okay and healthy and survived. But at the same time, it was a very eye-opening experience for them to focus on their own health and the ability to have support for themselves to help their mother. Then there's issues of social isolation and limited supports that we mentioned earlier in regards to self-neglect. And so they might live alone. They have no family, friends, or supports. Psychological issues kind of relating back to mood or any kind of dissociative issues that they might have had, longstanding kind of mental health diagnosis and so on, or concerns for abuse, which does technically happen. We've seen financial abuse, physical, emotional, sexual, and neglect. That's where myself or the other specialized come in, kind of take a critical look at things and see if somebody needs it to be in a safer environment. And then other. So maybe there's something we missed. Maybe there's something the doctor needs to bring to our attention.
Yeah, and this is just sort of the way that we showed it to you is just because it's so nicely organized in our referral form. But this is really just the idea of these are the things that again, it's not just our team. This is what we look at in geriatrics, right? It's very, like we mentioned, a complex patients, complex sort of social structure, complex everything. And, not every referral that we get has every single thing, checked off. Sometimes things aren't checked off. And then we go to the home and we're like, oh my goodness, the home environment is terrible. And, no one necessarily knew that because no one's going to the home. But that's sort of the idea of what our assessment involves and what we're always looking out for. And I think I can speak for everyone that even though the family, let's say, for example, the family physician puts sort of what they think is the issues, when we go to the patients, it's always going to be patient focused and sort of saying what is really their primary concern as well. So that's sort of something that we should mention as well. And it looks very overwhelming and sometimes it can be, but that's sort of the idea of what we deal and sort of care for. And so I think now what we can do is we can sort of sum up everything that we sort of talked about and give more practical cases. And sometimes they're not as catastrophic as it sounds like. Sometimes they are more serious. So we can give some examples of based on real life cases. So for example, we have Mrs. W. She's an 88-year-old woman who lives alone in a downtown apartment, happens quite a bit. No formal supports, but she has a very supportive and involved daughter. But this daughter is becoming more and more burnt out. So the family physician referred to our team with concerns. Specifically, they chose about safety around falls, medication adherence issues. In the context of cognitive impairment, I put in the MOCA as sort of the cognitive screening test you might have heard of. That's a low score, 13 out of 30. A normal score is 26 and above. So just to put in context that there is some impairment. Mrs. W thinks she's doing super well, and you're all too worried. And so she doesn't go to appointments. She doesn't go to our clinics, our outpatient clinics. Like, for example, I have a TRI or a Toronto Rehab or wherever our clinics are. I imagine it's probably a little bit even difficult for her family doctor to get her to come in. So this is sort of a really typical case of someone that we would see. So what's our response? So this is a case where I would go in, or my colleagues, the geriatrician team, we go in, we do a home assessment, we do our CGA, our comprehensive geriatric assessment. So looking at all the different aspects, and we notice and assess issues with cognition, issues with fall prevention, issues with medication optimization, and we make some recommendations. Sometimes they can be big, sometimes it can be small. For example, in this case, there were some, I think there were medication reviews. So there were some medications that maybe I recommended to come off, but for sure I asked the pharmacist to come by and see her. Fall prevention as well. You'll see some of those recommendations, and that's what the next sort of parts are. Is that I would go see this patient, or someone else on the team would have seen them first. We would sort of discuss our findings at these weekly rounds, and then things get escalated and more people come in. So for example, the pharmacist would come in and they would support those medication simplification recommendations that either I made or maybe the pharmacist, made those recommendations as well. Some things that we often do is we support using blister packs. So sort of changing the administration to a little bit easier from the vials or the bottles to blister packs to promote that adherence. Other things that we do often, not so much in this case, but we can also do these dispensing medication systems that we have. The home and community care support service coordinator supported the falls prevention issue by arranging that home occupational therapy safety assessment. We also got some limited but available physiotherapy to develop a home exercise program, because she didn't want to go to our Toronto Rehab falls prevention program that we have. Which would be another option that we could have recommended. And then our social worker would come in to counsel about, future care planning, alternative accommodation options, improving linkages with other local community supports, maybe for more activation, to minimize that social isolation and caregiver burnout that we saw highlighted by 1,000,000% in COVID world. So that's sort of an example, and again, of what we would do for some of our patients. And in this case, Mrs. W, and everything worked out. She's doing well, happily ever after because of us. Here's another case.
Yeah, so a similar case, Mrs. D. She's an 82-year-old woman living alone in a downtown apartment. Her daughter and son-in-law live in a different unit in the same building. So she was referred to us by the hospital, and on the referral form, they communicated to us that there were issues about incontinence, cognition, impaired cognition, nighttime restlessness, and falls. So this one as well, I believe the, can I see the IH response,
Yes.
please? So the geriatrician conducted an in-home assessment, including cognition and medication optimization.
Yeah, this one
and
I remember this one is more recent, and I remember that there was sort of this, we confirmed the diagnosis of dementia. I remember that was a big issue that we had. Anyway, sorry I interrupted.
Yeah, no problem. And just, as we're highlighting the different roles of each team member, I think it's important to note that everybody sort of like builds on the action plan put in place by, if there was a previous team member in. And what that also allows for us to do is really to help troubleshoot. So if there was a recommendation put in place, or 3 or 4, right? The next person going in will say like, so how is the medication optimization going? And are you having trouble with it? Let's review that. I know Dr. Steinman talked about this. Does that still make sense? So it's helping the patient and the care provider keep track and actually put these conversation and assessments into action. So when I went in, I did explore with the daughter caregiver supports. We talked about resources for hearing assessment. We talked about and came up with a plan for urinary and bowel optimization. And we were also I also helped to navigate expectations about the newly implemented home and community care support services. So that was something that was not part of their care plan before, and they were trying to understand it. So I was helping out with that. And the pharmacist, there were a lot of medication changes for Mrs. D. She was on a lot of over-the-counter supplements that weren't ideal. So she supported the medication recommendations and troubleshooting through any side effects. And also, I think there's social worker role. So she connected the daughter and son-in-law with respite care and also a safety plan for Mrs. D to increase independence and security in the home with false alert devices. The end for Mrs. D.
Yes. So yeah, we talked a lot. There's a lot to talk about. So hopefully I didn't get to see the chats. I'm going to stop the share right now. It's just so I can see everyone better and you can see us better. So now we're really hoping that we can have, I'm sure there's a lot of questions and we're happy to field them.
Actually, there have been a lot of questions
Yeah.
in chat. So what I'm going to do is I'm going to jump in and just ask you a couple of quick ones off the top because the others might be a little bit more involved. So there was a question about whether there are similar teams in Ottawa, Kitchener, Waterloo, and Barrie. Do you know if there are?
I did a little bit of homework as we're going through the slides. I found Regional Geriatric Program of Eastern Ontario, and there is a lovely map there that does show that parts of Ottawa are being served.
Okay.
And it looks like it's through East Geriatric Assessment Outreach Team as well as the West Geriatric Assessment Outreach
Okay.
Team.
I also know, and again, this is all just very local. I think you can assume for the most part, if there's a major city nearby with a sort of university or hospital sort of type setting, the geriatric services are usually around those types of supports, although, you know, there are, you know, in more sort of remote areas as well, but it's usually around a hospital. So it's not usually a community, sort of just a doctor in the community. So that's another clue. If you're looking for geriatric services in wherever you are, look for a hospital and look for clinics associated with a hospital. And again, looking at those regional geriatric of areas and their sort of websites would help with where they are located. For example, I know that in the London area that there are geriatricians who are doing home visits, but I don't know the details of sort of in what context and what the teams are. Even within Toronto, all the geriatric outreach teams are composed of different, some of them are just physiotherapists and occupational therapists. Some of them have a nurse. Some of them are sort of as involved as ours. So it really, there's no standard of what a geriatric outreach team should be.
Okay.
Or can be.
That's great. Thank you. That's helpful. Just two other quick ones, and then we'll get into the more involved ones. The question was, do you collaborate with HCCSS as well, or no?
I can say yes on a regular basis.
Okay, good.
Absolutely. Like earlier, we mentioned that home and community care does have a small representation in our rounds and in our team. I know when it comes to communication, we regularly try to advocate for possibly increased PSW hours, whether it be for personal care, medication reminders, meal prep, bathing, laundry, all those different kinds of services. And then those other additional services. So making sure a home safety assessment is done with the occupational therapist. So we can regularly connect with the LHIN, both either through our representative or through us individually connecting with the care coordinators, leaving them voice messages, sometimes doing home visits together with the care coordinator so we can discuss those important interventions that the patient herself is advocating for. And then we become an advocate for the patient to say this is what they're looking for, and kind of guide sometimes patients and families on how to navigate with home and community care to get those best resources possible.
Exactly. Okay, the other quick question, and then I'm going on to Sandra Thompson and to Francis. The other one is, do you have nurse practitioners on your team? And do you know of nurse practitioners being on other teams?
I can answer that that would be great to have a nurse practitioner. We'll take any amazing geriatric educated healthcare provider we can get, but we do not have a nurse practitioner on our team. I wonder, yeah, if there are, like Dr. Steinman mentioned, different teams have different providers. So I don't think it's unheard of, but our team specifically, no.
Yeah, I think we know that some of the naturally occurring retirement communities, the one I believe in Kingston has hired nurse practitioners recently. So that was one of the reasons for the questions. So
Yeah.
Sandra, you have 3 questions. If you can just try to make them brief so we can get everybody's in. Did you want to, Sandra Thompson, ask your questions directly? Yes, Sandra, you're on mute.
All right, thank you. Well, the question about activities of daily living was answered because you have the basic and then you have the higher level dailies of activity living. And what was the other one here?
You asked, I think, about activity of daily living assessments, how
Yes.
social isolation and elder depression.
Yeah, social isolation is a big one. I'm a senior. I live in a co-op. So there is activity in the co-op, and we're starting an aging in place committee in the co-op. And Wood Green across the street has a project going of aging in place. They got a grant to start a project going, and we're trying to sort of connect with Wood Green. But I see Wood Green is not in your catchment area, or at least we aren't, because our postal code isn't there. So, and I had a big concern about depression because having worked in long-term care for a long time, I've noticed that depression is not really taken that seriously in the elderly, and at least appears to be not taken that seriously. And with some even basic treatment, it can be improved. So because I suffer from it myself, so I am getting treatment. In fact, I see a cardiac psychiatrist because I had cardiac surgery 11 years ago. And this doctor works solely with cardiac patients. But that was my question really about depression and social isolation.
Yeah, it's a excellent sort of point and awareness that there is, you know, a significant issue of low mood, depression associated with, you know, with or without social isolation. And it was really highlighted, unfortunately, during the COVID pandemic and the restrictions of sort of physical isolation that we had, although it exists without that picture as well. And that is definitely something that as training in geriatrics, we definitely focus on that, and it's part of our, you know, assessment of every sort of patient that we do some screening, and I've, you know, we do treat, again, from my perspective as a physician and medical sort of background, my treatment is medication, but that's where I have sort of my you know, colleagues in the allied health, where there's other sort of things that we can do to help with, you know, the effects of isolation, to deal with the social isolation, get some more activation, etc. It is a huge part of what we do, and I can let Shana or Agnes speak to that as well.
All right, well, thank you.
Okay, that's great. Frances Morton Chang is handling the senior strategy in York Region, so she has a few questions for you. Frances, just to remind you, you were asking about people who are homeless, about whether public health and paramedicine also make referrals, and about Ontario Health Teams, how to scale the model to them. So go ahead. Are you there, Frances?
Oh, sorry. I thought you asked the questions for me.
No, it's okay. You go ahead. You expand on them. I'm just reminding you.
I'll start with the OHT piece, because it seems like this is a model that should be spread and scaled. And I know RGPs for, you know, decades have been doing amazing work. But I'm just wondering if there's an appetite, if you're sharing this widely, if there are programs similar to yours and we're looking at scaling and spreading them. So that would be the first.
Yeah, so I think that when it comes to sort of models of care, et cetera, it is, we do definitely want to, we have the data to sort of spread that. And I always rely on sort of above my sort of scale of, and our program director and chief of geriatrics, Samir Sinha, which you guys may be familiar with. So he's pretty critical in our development and sort of with potential modeling options. I would say that if there is an interest, practically, that's someone that we could connect you sort of with. But yes, I mean, we started off as sort of this pilot project. We didn't invent a geriatric outreach team, obviously, but sort of putting it together of different organizations, et cetera, is a little bit unique. So again, I don't have an answer of, here we go, here's our sort of paper on how to copy and sort of model a outreach team. And I'm more sort of focused on the clinical aspect. So I don't know the back sort of ground of sort of how to get the funding, et cetera, other than we provide our data to help support, asking for more funding, et cetera. So yes, so that's sort of what I can say is that I think there is appetite for that for sure. But we're sort of, I think, focused more on the clinical part. So I'm not the best person to give you the complete answer.
Thank you.
Francis, I'll speak to you. Asked if there's some inverse referrals. So I guess you're referring to, it's a great question, when sort of organizations that would typically live on our linkages list, if, in their encounters with older adults, do they think, oh, wow, you need a geriatric outreach team? So yes and no. In terms of Wheel-Trans, I mean, that would be really amazing if they could make a referral to us. But the inverse referrals that I see happening are, for instance, through home and community care. So we're really often making referrals there, seeing what would be appropriate with our liaison on the team. But also oftentimes they will alert the family doctor to say, hey, I filled out the application. Like, this person really needs a geriatric outreach team. Please review it and send it in. So there's home and community care that's making referrals. Also, I find we are sometimes getting referrals from the other geriatric outpatient services. So whether that's the day hospital or the falls prevention program, they will also say, hey, we saw this person a couple of times. We really think that they need outreach. That might be a better fit. So can you please consider them? Yeah.
Great, thank you.
Okay.
And what about NGOs though, like an Alzheimer's Society or?
Yeah, so yeah, that's really a good point. And I think that we have thought of them and reached out and gone to speak with them. I remember there were a couple of presentations over the years to Alzheimer's Society. I'm not sure if anything has materialized, but it just might be that we might not know about it. It might be the organization talking to the family member or the patient, and then them bringing it up to their family doctor, and then we see it as a family doctor's referral.
Yeah, because we're sort of a medical sort of model type thing. It's doctor to you sort of need that MD or NP referral to sort of start the process. Even though there are, like Agnes said, maybe, care coordinator initiated or other people initiate the sort of referral and know about it and then ask the family doctor to send it over. So we're sometimes losing that who's actually making that initial sort of referral, but we're hoping that that's happening. But because it is sort of a medical model, as opposed to like things like Alzheimer's Society or even home and community care, where you can, for some things, can just sort of self-refer as well. This is more of a medical model, just because that's where we were born and where we come from. So that is that need that physician official referral.
Thanks so much.
Okay, Nicole Baudry in Sudbury, just on that note, I think you had some questions about dealing with a physician. Is Nicole still with us?
Okay. Well,
yeah.
Around here anyway, many family physicians are really focused on, when you visit, bringing only one question, one big one or two small one. So so that means that this physician has no lens at looking at decline, at mobility, at nutrition, at anything secondary to what the symptoms are. And how do we go about saying, hey, there's something serious that you can't check because we keep multiplying whatever is going wrong?
Yeah, this is sort of an issue of sort of a system issue with our care. Unfortunately, now not just in Ontario, not just in out of throughout Ontario, throughout probably the country, throughout it happens in lots of places where the family physician is very much focused. The visit times are small, and we're talking about I'm telling geriatrics, we see everything here, but it's we have the leisure to take that time. It's built into how we're compensated as well. So that's also something we take into. So I think in that context of, okay, this is the reality that we are now, as much as we want to change it, and hopefully things can change, et cetera, how would I recommend dealing or sort of traversing that sort of difficulty would be, number one, I don't know how often you're allowed to make appointments or how easy it is to get appointments, but sometimes if you do make an appointment, that's focused just on that sort of issue. So it's not the usual, it's not the, okay, I'll see you in 3 months to follow up on your blood pressure again. You can say, no, I want to see maybe an earlier one or whatever it is, if they let you. That's one way. So making that your big issue. The other thing that I can mention is if there is things like mobility issues, are things that, functional issues, you can self-refer to home and community care. So you can get a care coordinator that can make some of those, part of their assessments is looking through all these different things that come up in our geriatric assessment. So that might be a way to start getting assessed and maybe get some supports through sort of community resources. The other thing is I'm saying, yeah, let's make referral to geriatric wait lists are very long, and we're aware of that. Our team, we work really hard for I think our wait list is 3 weeks, 3 to 4 weeks to just at least get sort of a first person connected, which is extremely fast. And we work really hard to reach that. And that involves also triaging, making sure that we're getting the right type of people within our system of sort of the geriatric hub at Sinai and UHN. But that's not a typical sort of, maybe they'll be able to see, not that it's nothing, but they'll be able to see someone on the team, but until they're able to see, let's say, the geriatrician, it takes time as well. But so anyways, long story short is looking for sort of those resources that go around the support as opposed to just the physician. So I think that might be one way, and getting the home and community care. It's available throughout the province. Again, it all depends on where you are, what supports are available, but getting plugged into some sort of system where there can be some supports would be what I would say if you can't get sort of faster assessment by a physician.
Mm-hmm.
Okay, there is a question about whether your team has people who speak different languages on it or whether you use interpretation services.
Bit of both. So yeah, we do, first and foremost, we're using language line. So oftentimes when I go in and see a patient, I'll dial it in. So then we do have an interpreter on the phone. And then informally, I do speak Polish. Are there any other languages on the team? I think
Not useful ones.
Yeah.
I know we tend, as practitioners in our own right, we tend to have some students with us from time to time. And sometimes our students come from international different areas, or they have their own backgrounds. So I know I can speak from experience. I have a student right now who speaks Cantonese and some Mandarin. So I do my best to either almost as a win for everybody. They get to be a little bit of a translator. They get to have that experience being with the practitioner and with the client or patient. So in terms of if we can't use the language line, but we do have somebody within our field available to us as the translator within our team, really, we'll use them then.
So we do have, like we mentioned, the language line, which is official medical translation that's provided. We use through our UHN sort of route that has access to I think pretty much every language, but as soon as we get creative, sometimes if we want to get in person, that's usually on the phone. And sometimes you can imagine that there are hearing impairment issues, or sometimes it's just hard, things get lost in translation when it's on the phone, literally. Sometimes we've had cases where, I don't remember if it was Agnes or it was Shana, someone coordinated for me a in-person interpreter from our Toronto Western site, because the home visit was close to that hospital. They agreed to come to a home visit with me, and that was amazing. So it was for Portuguese interpretation, which was so helpful. And other creative things that we do is the home and community care also has access to in-person translators or interpreters, or I don't remember which one's the right way. So sometimes if we do joint visits, we can, have that in-person translator come in. I had that recently for a patient who spoke, what was it, Omoro? It was the language from Ethiopia. So we got that interpreter to come in, because it was like a sort of, I don't know, it was difficult to find out on the phone interpreter for some reason, even though it's the main language in Ethiopia. And we were sort of lucky in that way. Sometimes we have to do informal translation if sort of that's not working with family members, but we do try to avoid using family members as translators, because we know that there could be, biases, etc., or, some intentional or unintentional sort of, screening of what's being said. So if it's really for a big serious discussion or something where we really want to make sure that we're getting the actual sort of communication from a patient, we'll use a formal trained medical interpreter. But it's I think it's actually a nice, it's sometimes a barrier, but sometimes it's it's nice that we have that diversity, and we're able to sort of meet the needs of our patients.
Okay.
And I'm trying to learn Portuguese. It's
Good for you. Okay, that's great. Does anyone else have a question before we wind things up? I'm not seeing any hands up, or okay. Okay, in that case, I really want to thank you for a very, very informative presentation. And I have to tell you, I was very gratified to see that SSAO's top two policy priorities, which are community care and home care, were where you get most of your questions or requests for service. So that confirmed it for us once again, that's what, where the focus needs to be. So we continue our efforts to pressure government around those two priorities, because we know that it's a big problem. But all of you have been wonderful in answering questions, and I'm doing an excellent presentation. And the comments were very nice as people were leaving. So thank you so much. And